hey, this slide's important. This little bit of information is what you need to look at.
Matt, can you adjust the projector? Go left a little bit.
Can you scooch it?
Get it, Matt. There you go.
Very good.
Thanks.
Was it doing that yesterday?
So if y'all need a minute, if I say something that's not written on the slide, you want to take a second to write it down, just let me know. And we'll keep cruising. We'll go through this pretty quick. So the important things here are to know that the pneumatic compression pumps come in various sizes and lengths. They can go single compartment for uniform pressure, or they can do a sequential pressure like the one we have in the lab. Pressure is always greater distal than it is proximal, and we can add cold to the compression. It's easy. And we'll talk about static compression. It's important to know what static compression is using the bandages. What does it do? Shapes residual limbs, controls edema, prevents abnormal scar formation, reduces the risk of DVTs. That's an important slide as well. These are always important, understanding what it does, what the contraindications are. What is edema? Biggest thing I want people to understand is that edema is not a pathway that fluid travels through. It travels through the lymph system. So edema is not a pathway. And then acute edema is usually due to tissue injury, inflammation, localized redness, warmth, all of that, that's acute. When we start to have loss of contours of the legs, it's venous edema. It's the biggest difference between an acute edema and venous edema. You get the loss of contours. The pump. The heart pumps blood through the arteries and veins. There's no actual pump for the lymph system, so we use gravity and all that. We'll get to in another slide. But if there's an arterial impairment, because the blood, all the fluid and proteins comes out of the arterial side in that capillary bed, some of it gets processed out by the lymph system, the rest of it gets reabsorbed into the venous system. If there's an arterial impairment, then the interstitial space where the capillary bed wouldn't work efficiently, and we won't be able to pump out as much as we would. So if there's arterial impairment, the interstitial space where the capillary bed would not work efficiently. That's important. But if it is working properly, when 90% of the fluid that is filtered out from the arterial side gets reabsorbed on the venous side. 90%. This piece right here is important. What does the lymphatic system do? Regulates fluid balance, defense against infections and cancer as part of the immune system, and transport digested fat from the gut. Without the lymph system taking care of all the extra fluid, we'd be done in about 24 hours. And then since it doesn't have the heart to pump, it uses its own gravity, muscle contraction, and respiratory pressure to help pump fluid through. It's all important stuff. The biggest thing I want you to remember on this slide is we know we elevate and help with swelling. When will we not elevate a limb? It is ischemic because we left the arterial blood flow and then bad business. Pressure settings around 30 to 40 are recommended because a lot of these pumps we can't truly know how much. Is not a very accurate measurement, and we could potentially damage some of the superficial lymph vessels if we get too high. So 30 to 40 is kind of a general, but we can go higher, and there are other recommendations we'll get to in just a second. We don't want to exceed the diastolic blood pressure. We talked about that in lab 2, because if we go over the diastolic blood pressure, we start to restrict arterial blood flow, and then we can create a medical emergency. These numbers are pretty important too. For upper extremity, we're typically between that 30 to 60, lower 40 to 80 because you need more pump in the lower body. That's the important stuff on that slide. So knowing the difference between long stretch and short stretch, as well as the next slide, that multi-layered and what they're used for. So long stretch is mostly with immobile patients, people that are passively laying in the bed, where short stretch will work with the flaccid or inactive limb. So we put that on people because as the muscle contracts, that's where we get the pump. And then the multi-layered is mostly used for venous stasis ulcers. Those are all important things. And then there's your chart that talks about all of that. The only thing we'll really focus on with the CDT therapy is about the skin care and how the skin loses elasticity. So keeping it moisturized, keeping some of the elasticity can help you pump all that stuff out. So that's the important stuff on that slide, on that PowerPoint. So then we go to the lymph system. Most important thing in this set is I want you to really understand the staging system for lymphedema, how we use the degree of fibrotic tissue based on palpation, and then the severity is based on the percentage. Those are on the next slide. Where we have subclinical, stage 0, there's no apparent swelling, even though there is impaired lymph transport. Stage 1, you still have the soft pitting edema, but it reverses when you elevate the limb. Stage 2, the pitting edema gets a little bit worse, and it doesn't reverse with elevation. You start getting fibrosis and fatty deposits, distortions in the limb. And then stage 3 is no longer pitting edema. It's got the thickened, discolored skin, more fibrosis, fatty deposits, and more architectural distortion. So kind of being able to differentiate between those. And then the percentages. Mild is less than 20% above the baseline, moderate between 20 and 40, and severe 40% above, or more than 40%. Biggest thing, the lymph system's a one-way path. So there are valves throughout the lymph system between the nodes and everything that help block any backflow because it only runs one way, so we don't want anything coming back. So it's a one-way path, and there's valves between there to help prevent backflow. Everybody good? One thing I forgot to mention that is one of the, I think it's on the quiz maybe, is it talks about the FDA. In any device that we're using, all these modalities are approved by the FDA. We can't start using anything until it's been approved by the FDA. And I just want you to know or remind you that the FDA is an organization that assures public safety by requiring that before being approved, all devices have to be proven safe and effective. Organization that assures public safety by requiring that before being approved, devices must be proven safe and effective. I think everybody knew that, just a reminder. The biggest thing with diathermy is what kind of conversion. It's the biggest thing that I want you to remember with diathermy. We have the electromagnetic field, start talking about laser, we talk about the rainbow. What's a rainbow have to do with anything?
Invisible.
Spectrum of visible light, right? So you don't have to memorize the frequencies for those visible lights. Reflection, refraction. Biggest thing for UV light is that we use it to use it for some dermatological conditions, but the biggest thing it's used for is preparation for wound bed healing. And then with the UV, other thing I really want you to be familiar with is this, that chart. So you have the suberythemal dose, which we have no erythema. Everybody knows what erythema is? Redness. But we do get some vitamin D production with that. So suberythemal, and then the minimal dose is the smallest dose. We get some erythema between 1 and 6 hours, but it's gone after 24. And then after that, it goes up 2.5 times. So first degree is 2.5 times that minimal dose. Yeah, erythema lasts in for 1 to 3 days, and then it doubles after that. So then we go 5 times and 10 times. We have intense erythema. You start getting more peeling and more pigmentation in the skin. And then with that third degree, you get severe blistering, peeling, and exudation. So being able to tell the difference between those. Biggest thing about laser is we want to remember that laser is monochromatic, where white light, other forms of light are multichromatic. That's a piece of cake, right?
Sure.
Any questions? There are none? Excellent. That was easy. Alright, so before we go down the hall, who else is going down there? Anybody? Anybody? Bueller?
Is anyone that wants to?
Yeah.
Oh, okay.
Especially
I heard her talk
anyone that
about it yesterday.
struggled in Bio 150 to let them
Yeah.
know, like, it's
So-
gonna be fine.
Foundation of electrical stimulation. A lot of fun stuff we was talking about. Electrotherapy. Commonly used for a variety of therapeutic effects. Muscle strengthening, pain management, muscle re-education, stimulation of nervated muscles. So those are all important. What do we use them for? Sounds like a good test question. And then we have therapeutic effects, which you guys can read if there's any questions. Biggest thing that we mostly use it for is muscle re-education, strengthening, and relaxation, pain management. Those are the biggest ones. Indications, variety, pains and muscle atrophies, contraindications, pacemakers, malignancies, pregnancy, carotid sinus, seizures. Alright, here's our abbreviations. These are the ones that are going to be on the test as short answer, because there's no other way to test your knowledge on these. If I gave you matching, it's pretty obvious. So these are all short answers. EMS, electric muscle stimulation, ESTR, electric stimulation for tissue repair, NVS, neuromuscular electrical stimulation. These are also on page 273 in your book if you want another look at it, but it's the same chart. Functional electric stimulation and then transcutaneous electrical nerve stimulation. Those are all the different varieties and ways that we use electrical stimulation. Explanations, you got the treatment goals for everything, which we get into a lot of these in future lectures, so we're not going to take too much time to talk about them now unless there's a specific question. But PTAs need to understand the muscle and cell membranes and how they respond to electrical stimulation. So muscle and nerve cells are excitable because their ability to produce action potentials. It's one of those things we talked about in anatomy and physiology, is that action potential. It's the change in electrical potential between the inside and outside of the nerve cell. Muscle nerve cells regulate that exchange between the inside and outside of the cell, and potential difference in the concentration and permeability of sodium potassium ions is termed resting potential. Does everybody remember that, the sodium potassium? There's a little bit of chlorine involved in there too. Yes, no, maybe so.
I remember hearing it. I don't remember learning it.
So like, if you have the nerve cell and you have a lot of sodium on the inside and it's on the outside potassium, or vice versa. And then when these are positively and negatively charged, and when you introduce stimulation, it'll change that polarity of the cell, which creates the action potential. I also have a video we can watch real quick just as a reminder. It's just more about the actual contraction, but it's the closest I can find. But we need to understand the difference. You can't even see that gray marker.
Nope.
Y'all could have told me that.
I'm about to.
That's fine. So creating the impulse in a muscular cell requires the resting potential to be produced by a threshold level causing changes in the membrane permeability. So basically we need to charge it strong enough to make that happen. And then this creates an action potential that results in depolarization. There's a picture kind of on 275 in the book also. We'll watch a video here in a second. But in order for an action potential to be evoked using electrical stimulation, the amplitude and the pulse duration have to be sufficient to overcome the established resting threshold of the nerve system. Sound? Nothing. Right? It's a bummer.
I think volume's up all the way. What about the computer volume?
So this is just talking about how the neuron itself creates that electrical stimulation. But we do the same thing with the beef stem.
We did it at the same time.
There is volume though. Click it.
Do you have the link to this video?
I can.
The volume?
Oh, it's a megaphone.
But like, wow.
Just send it out. It's not important. I mean, it's just kind of helpful for understanding that. If y'all have forgotten the anatomy and physiology. Nothing?
Nah.
Do it again.
It's really right now. I can just play the volume of it out.
We tried. How about
Put in your own.
Copy it in the group. Yeah. There it goes.
The action potential releases adrenal stores in calcium and phenomenal stimulates muscles.
I'll send it to everybody.
I'm about to put it in the group me right now.
Basically, we're creating a charge that's strong enough to cause that transfer of positive and negative electrodes around that nerve cell to move, creating action potential. So if you look on page 275 in the book, it shows you where the positive and negative electrode are placed and how, we'll get to this in a second, but the positive electrode pushes the positive ions away towards the negative electrode, and that's what causes that actual potential.
I sent the link for the video in the group me.
Thanks.
You're welcome. Well, if anyone wanted to look at it like right now, they could.
It's a 2-minute video, and it talks more about the myosin control and all that. But the very first part of it is talking about the action potential. And that's all. I just wanted to refresh your memories so nobody was confused when we were talking. So we'll refresh your memories on the action potential, but change the positive and negative polarity of the cell creates muscle action, like on page 275 and on that. So as we get into electricity, we'll talk about the principles and what things mean. We have current, which refers to the direct flow of the charge from one place to another. In order to produce an electrical current, there must be these three things. These three things are important. You have to have a source of electrons, which is your nerve cells, sodium, potassium, chlorine. It's your source of electrons. You have to have a material that allows the passage of electrons, also known as a conductor, which is your skin. And then you must have a driving force of the electrons, or an electromotive force, which is the stimulator. Current is measured in amperes, and you don't have to remember these numbers, but 1 ampere is equal to 6.25 times 10 to the 18th electrons per second. And then you break it down further into milliamperes, and thousandth of an ampere, and then microamperes is 1 millionth of that. Again, you don't have to remember all of that, you just might hear it. Then we talk about voltage. Voltage is the driving force. The electrons will flow between 2 points when there's a difference in the quantity of electrons between the 2 points, such as inside and outside of that muscle cell between the positive and negative electrodes. Voltage is measured in volts.
Really?
And then resistance is the ability of the material to oppose the flow of ions through it. It can be calculated using Ohm's law. It's measured in ohms. And the current in a conductor varies in proportion to the voltage and inversely with the resistance. So current is directly proportional to voltage and inversely proportional to resistance. So as the resistance goes up, if the voltage is the same, the current is diminished, right? There's more resistance. If the voltage goes up, the current goes up. So directly proportional voltage to current, inverse to resistance. So basically, a force of 1 volt is required to drive 1 ampere of current across the resistance of 1 ohm. It's a simple way to look at it. But the skin resistance is high, we need more current to get through, so we have to increase the voltage, which is why in the lab, some people wouldn't feel anything when they got all the way up to 14 or 15, and some people would feel it at 3. Because that resistance, we have to get that voltage high enough to be able to actually cause that sensation, cause the feeling, cause the change of electrons. And we need excitable tissues to conduct the signals. The excitable tissues are our nerves and muscles. Everything in the body has capacitance, which is the body's ability to store a charge in an electric field and oppose the change in current flow. These are our muscles. Muscles and nerves are known as capacitors. In the body, they also act as resistors because they oppose the change in current flow. So while they are capacitors and they hold that they also oppose it. So resistors can be in parallel or in series. So when we talk about fat and adipose, things like that, those are resistors in series. So when the electrical stimulation hits it, it only has one way to go, just through that series. So once it gets through the fat, the adipose, the muscles and nerve cells are resistors in parallel. So then the muscle has, or the electrical stimulation has a choice of where to go, and it always takes the path of least resistance, which is why even though we put those electrodes on the same place on everybody, for the most part, some people had different digits and things moving because the electrical stimulation travels through that path of least resistance, and on one person it may be this digit, the other person may be this digit, and it also has a little bit to do with replacing electrodes. But adipose and skin are resistors in series, and muscles and nerves are in parallel. So if you have a patient that's apprehensive, one of your goals is to make them as comfortable as possible. So if you know it's going to take less intensity to accomplish the goal when the resistance is lowered, then you should probably do that. So as we get into impedance and resistance, heating up the tissues and using some water will help increase the conductivity and lower the resistance. So if someone's really nervous and you don't want to have to zap them at 100 volts, we could try heating the skin up a little bit before. We could try to put a little bit of water on the pads, with a little squirt on wherever you're putting it. So impedance throughout the body varies, and conductivity is dependent on water content. So healthy skin has a thin layer of water, but offers the highest impedance to current flow because the outer layer doesn't have a lot of fluid. So deeper layers, more moisture, more sweat glands. So skin resistance is inversely proportional to temperature, meaning if you heat the temperature, it lowers the resistance. And then water will too, because we don't have a lot of water readily available on that top layer. So wetting is going to help conduct electricity. Then bone fat, tendons, fascia are poor conductors with low water content. You don't need to remember the percentages. But with smaller amounts of adipose tissue, it's going to require less intensity to elicit a response. So inverse proportional. Smaller adipose area, less resistance. And intracellular components of nerve and muscle have a higher water content. Their membranes also have a high resistance that opposes change in charge and movement, which is why we talked about that series and parallel. So bone, fat, tendons, series, nerve, the electric stimulation just goes one way through it. And then once we get to the muscles that have a high resistance also, that electrical stimulation will find that path of least resistance to be able to get through there. So impedance changes in the presence of injury. So if you have any edema, ischemia, arteriosclerosis, scarring, or any denervation, it's going to increase the impedance. Swelling, we got more stuff to get through. Scarring, there's more pickets and stuff. With open wounds, things like that, the impedance is going to be less because the wound's open. We're not having to go through that dermis or epidermal. And usually there's going to be some fluid in those open wounds that's going to increase conductivity. So as we go through, we want to minimize the impedance as best we can to allow the intensity to be reduced, and increase the patient comfort. So cleaning up the skin using an alcohol wipe to get rid of any body oils, any excess body hair. No one's really going to be shaving people's arms and legs and everything, so it's just, you got to deal with it. But then keeping the area up, and then with continued electrical stimulation, you reduce the impedance because it's constantly going through. So current will flow if these two situations are met. The source of energy creating a difference in electrical potential and conducting pathway between the two potentials. So we need enough voltage and have a conductive pathway. Ionic flow occurs in the underlying tissue. So as we start those charges, the like charges will repel and the opposite charges will attract. So So under the positive ion, this is good, page 275 to kind of follow through and visualize it a little bit. But under the positive ions, which are known as the cations, they repelled by the positive electrodes and migrate towards the negative, and the negative ions, also known as anions, will leave and migrate towards the positive electrode. And that's a perfect picture on page 275 of what we're talking about. How we have under the positive electrode that hyperpolarization, where the positives are outside the nerve cell and they move in, and then as they run through towards the negative ion, the positives go in, the negative ions come out, and we get depolarization. So the nerve's positively charged on the outside, negative on the inside, less excitable under the positive, more excitable under the cathode, the negative. So we call that negative the active electrode, because that's where the nerve activation takes place, and there's that depolarization. So hyperpolarization under the positive, and depolarization where that action potential occurs under the negative. Everybody following that? A lot of science. Everybody's having fun, right?
Yep.
No.
So with the change in ions, there's typically chemical reactions. So the sodium ions, which are those positives, migrate towards the negative pole and combine with water and form a base sodium hydroxide reaction at the surface of the skin, which is going to soften tissues. And then the negatively charged chloride ions migrate towards the positive pole and combine with water to form hydrochloric acid, which causes a coagulation of proteins and a hardening of tissues, which is why we don't want to put pads on somebody and leave them on there for a long, long period of time, because we can run into some tissue damage. With direct current, that iontophoresis, we're getting a big polar change because it's constantly running from that positive to negative. So that's why we want to be careful with the intensity. And then typically after a direct current treatment, there's going to be a lot more redness and change because the pH has changed. Your body's fighting to maintain that pH. We get more hydrochloric acid developing, sodium hydroxide, so the body starts trying to adjust to the pH. Anybody know what the natural pH of our skin is? Heard a lot of numbers. So 7 is neutral. So like water would be a 7. Our skin is a little more acidic, so it's between 4.5 and 5.5. It averages out around 5.5. Just a tip. Alright, so direct current. Mine has a little animation showing the
So
current.
does mine.
Well, that one's not.
Ours
But
is.
it's a constant flow. Does yours? Yeah. Oh, what's going on with this computer?
Sometimes you have to press like a specific button. to
So
make it
direct current is characterized by a constant flow of electrons from the positive anode to the cathode for a period of greater than 1 second without interruption. Basically, the biggest thing you want to remember about direct current is it's one way, red to black. Hey. Just gotta use that. I take it that this computer's great. Alright, so with direct current, polarity remains constant because it's flowing one way. And we can change it based on treatment goals. We can modulate the direct current. So we can change, after 1 second, we can reverse the polarity or start increasing or decreasing the amplitude to try to help people accommodate. Some direct current machines have all this stuff set up anyway and you can't really change a lot of it. But typically it can be modulated and most often used with iontophoresis. Alternating current is the ones that we're typically going to use with electrical stimulation. And this is, the polarity is constantly back and forth between positive and negative. We get a change in direction of the current flow. Alternating current is biphasic. It can be symmetrical or asymmetrical, and is characterized by a waveform that is sinusoidal in shape. Everybody know what a sinusoidal means? It's just like ultrasound is a sinusoidal wave. It's just that wave shape. Where direct current's not sinusoidal because it's that straight line. So if we look at wrong way. Here, we just have straight line. There's positive, negative. It's a straight line of positive, no change. And then we get into the alternating current. We have that sinusoidal wave. So it's positive, then negative, positive, then negative. It alternates, which produces a non-net effect. There's no polar charge with alternating current, as long as it's symmetrical. Does that make sense? Ish. Okay. Then we have pulsatile current, which is a non-continuous flow of direct or alternating current. So a pulse is defined as a discrete electrical event separated from other pulses by a period of time with no electrical activity. So, hold on. So, a pulse is defined as an electrical event separated from other pulses by a period of time with no activity. Just like when we do ultrasound and you have that pulsed wave, okay? Pulses. So we have a line here, positive, negative. So the space between these dotted lines would be a pulse. And then each of these are going to be phases. So when we talk about biphasic and monophasic, which we're going to get into a little bit, but a pulse is this period of time that's separated by periods of no electrical stimulation. Does that kind of make sense? So you have monophasic pulse current, where there's one phase for each pulse, and the waveform is either positive or negative. This would be an example of a monophasic positive polarity, right? Because all the charges when they activate are on the positive side of the line. So that's monophasic between the pulses. And then we get biphasic. Biphasic would be two phases, one positive, one negative, and these can be symmetrical, asymmetrical, balanced, or unbalanced. But a biphasic pulse would look like this, where there's a positive phase and a negative phase within one pulse. Does that make sense? Yeah, okay. I think there's a picture of some of that stuff in the book too. So, monophasic, biphasic. Then we talk about symmetrical and asymmetrical. So the negative and positive phase could have a different shape and potentially a different amount of charge in the symmetrical waveform. What's that one we drew over there? Is it going to be symmetrical or asymmetrical? It's probably not perfect, but it's symmetrical. I'm no artist, so don't judge me based on that. Drop a lid. Alright, so asymmetrical, there's going to be typically a net positive or negative because they're imbalanced. Symmetrical, there's going to be no negative or positive charge because they cancel each other out. So in the quadriceps, a symmetric biphasic square wave was perceived as more comfortable. You don't have to really remember all the like squares, triangles, there's all kinds of different shapes for these waves. which are more for your understanding of what's happening. It's not actually what happens when you do that, because people's resistance is different. But symmetrical, large muscles. That's the name we want to remember. So an example of a balanced current. The shape of the pulse allows for positive and negative effects so that we have no net positive or negative. As opposed to this one, it's unbalanced, and I know it looks very similar, but if you look closely in there, they're not even, positives and negatives. You have kind of this short little negative, longer positive, longer negative. Here we have long positive, long negative, short positive. So would this be more net negative or net positive on this side? I think we got negative, negative, and then positive. And this side we have positive, positive, negative. So you see how they look very similar, but that's unbalanced. So there's net positive here, or net negative here, and net positive here. Does that make sense? So the unbalanced are the most likely to produce a net charge. And then this is just an example. This is in the book too. I don't know what page it is. I should write this stuff down. But these are just examples of the shapes that we get with electrical stimulation. But this is an example of direct current, how it's going to be net positive, net negative. We can, on some machines, create some modulation to have it be positive for a little bit and negative for a little bit. Then we have sinusoidal, and then we have all these other different kind of shapes that just talk about the way that the electrical stimulation is being applied. So we'll get more into that later on too, but again, that's just kind of a visual aid. There's some more here, monophasic, biphasic, and then we'll get into polyphasic in a second. But here's you get symmetrical, asymmetrical, unbalanced, asymmetrical. And a lot of these just talk about kind of the ramp up of the electrical stimulation. Up, holds it, drops off, goes negative, where this one kind of ramps up slow. So these are just kind of ideas for you to visualize how that electrical stimulation is being applied. These aren't actually what's happening in the body. All right, any questions on this stuff? We can go back over anything, look at pictures again. All right, let's take a break. So,
The top possible could be either positive or negative.
positive, negative, we have our phases. Is that monophasic or biphasic? Biphasic. And this will be what? So then we have polyphasic, which is bursts of 3 or more. So, I can have some pictures here. You can have 3 bursts, 1, 2, 3, 3. And then we have 3 pulses, 3. So polyphasic is composed of 3 or more phases where we have bursts, and the bursts are perceived by the patient because they happen so fast as 1 pulse. Kind of like in the lab, those of you that tried the 100 hertz versus the 50 versus the 1, that's kind of those pulses per second. So when we're at 100, we're getting a lot more, but it feels more close to 1 pulse than when you go down to the 1 hertz, it felt a lot more pulsing, right? So The burst can also be a group of monophasic or biphasic. So all of these are monophasic examples, but it could just also be the biphasic burst. It doesn't have to be monophasic. And Russian stimulators are an example of this type of waveform. So just think about the waveform, because the ones that you select are going to affect the patient comfort, their fatigue, and then any polarity or chemical effects on the skin, depending on whether it's monophasic or biphasic. So the shape of the waveform is influenced by capacitance and reactance of the tissues, which is, like I said, all those diagrams are good examples of the shape of the waveform that we're trying to give. Because of the capacitance and reactance, the body tissues are going to change the shape of the delivered waveform, which is why the diagrams aren't exactly what the patient's going to be getting. They're just good ways for you to see that waveform and what we're doing. So we have amplitude, peak amplitude, or the peak current or peak voltage. This is the maximum current of the voltage delivered in one phase. The intensity of the stimulus is one factor for determining the strength. It's also one of the three criteria necessary for depolarization. So the stimulus has to be strong. We talked about that earlier. And that's pretty self-explanatory. I feel like the peak amplitude is right here. Right? And then if it's a sinusoidal wave that goes like this, the peak amplitude can be here. Here, right? Peak positive, peak negative. So, we have 4 clinical levels of stimulation. I would probably know these. Subsensory. There's no nerve fiber activation, and there's no sensory awareness. So when you guys slapped on those pads yesterday in lab, we started turning it up, and maybe they got up to 5 on the voltage, and they said, hey, do you feel that? You said, nope. There was still current going through there at that point, but it was subsensory. You didn't have any feelings yet. And then we started getting into the sensory, which is a non-noxious paresthesia. And that's where everybody talked about, oh, it feels kind of like my hands asleep, right? It wasn't painful, but you have that paresthesia. And then you can kind of get tingling, prickling, pins and needles. It's where we're activating more of the A beta nerve fibers. So that's where you started feeling it a little bit more. And then as we turned it up a little bit more, bless you, we started getting into that strong paresthesia, and we started getting some muscle contraction. So people's hands started jumping around and doing stuff, or you could see stuff twitching up here in the muscle fibers. So we're getting to that motor point. We're getting more A alpha nerve fiber activation. And then when they say, hey, can you take a little bit more? I said, sure, crank it up. Then we started getting to that noxious point. It was strong and uncomfortable paresthesia and strong muscle contraction. And if you keep going more, you can get into that sharp burning sensation if you keep going high enough. And here's where we have more of the A delta and C fiber activation. Those all make sense. Different levels. Everybody kind of that's had lab felt a little bit of that. Maybe not. Maybe didn't get to this part because you got to a really strong one here, and you were like, that's enough. So we didn't always get to this, but that's what's next. All right. Amplitude. We have rise time and decay time. That's what it sounds like. The rate of rise is the ability to excite nervous tissue. The rate of decay is the time it takes for the peak amplitude to decrease back down to 0. Pretty easy, right? Then we also have interpulse intervals, or interphase intervals. And it's the time between the end of one phase and the start of the second phase, and the peak amplitude returns back to 0. So if I have this wave, this phase here, there's a phase 1, there's a phase 2, and then this time right here would be what? interpulse interval. It's that time between the phases. Measured in microseconds. That's how you write microseconds. And that's one of those settings, like when we did the lab, we said it shows you to set it to 200. That's that pulse interval. So we have intervals that allow the tissue to adapt to the current and neutralize the chemical effects between the pulses. So rather than leaving on that constant direct pulse or longer, less intra-interval space, you get more of a net polarity change. So having that little break where we're not sending that electrical signal for a second helps prevent some of that hydrochloric acid formation or sodium hydroxide formation. So it protects the skin a little bit, but it also makes it a little easier for the patient to tolerate the current. So phase duration is the time of the phases, which is opposite that interpulse interval. So phase duration is the length of the phase, right? So it would be measured this piece here, or this piece here, and this piece here, being that phase duration. So this is where we get tissue excitability. It's what determines the strength of the stimulus. This can also affect the patient's comfort, and you can typically change that phase duration and make it longer or shorter. You can change the amount of chemical effect, because if you have it on for a longer period of time, you're more likely to produce that chemical hydrochloric acid formation, sodium hydroxide, impedance, and then the discrimination between excitatory responses. So basically, this is just how we control how much electricity is they're getting, which affects all of these things. All right, we have charge. Charge relates to the strength of the stimulus. Potential for tissue damage is dependent on the values of other parameters such as the duration as well as the charge. An adequate phase charge determines the excitability. An excessive phase charge results in damage. So if we get too high, we get past that 4, that level of stimulation where it's that noxious, really big muscle contraction. We're like, I'm gonna keep going. And then we can get into tissue damage. Adequate is where we actually send enough voltage, we get enough charge to make a muscle contract or to make that depolarization in the cells happen. So that's our charge. We have pulse trains, which is basically, again, what it sounds like. Trains contain individual pulses and have time-dependent characteristics just like everything else. Pulse duration and interpulse intervals, all that stuff is the same. It just happens in tandem. So each train is separated by off times, the intra-train or interburst interval. This also helps prevent fatigue, chemical effects, and polar effects, all that stuff. So just trains of those bursts. These are all different ways that we modulate that current, right? We talk about modulation. This is how we do it. So then we get to frequency. Frequency is also referred to as the pulses per second, or the pulse rate. All of these various ways to describe frequency, I'll make sure you understand too. Just look that way when you hear pulses per second, or you hear pulse rate, or you hear frequency, kind of understand what we're talking about. So the frequency is expressed in hertz, and that's one of those settings that we changed in the lab, right? We changed that frequency, so we changed the hertz. So we have burst frequency, which is the number of bursts per second. The body responds to the number of pulses, not the number of phases. So again, those phases are oftentimes felt by the patient as one pulse. So the pulse is really what the effect is, and it's the accumulation of those different phases inside of the pulse. Does that make sense? For right now, this moment it does. So a single monophasic, biphasic, or polyphasic pulse is counted by one pulse in the body, regardless of the phases that are inside that pulse. Impedance will decrease as the frequency increases. So as we crank up the hertz, the impedance that the skin is getting is going to lessen. So then we can get to a muscle twitch when at least one motor unit responds to the stimulus. So that's usually around 35 pulses per second or less than 35 pulses. So we're getting muscle twitch less than 35 pulses per second. And we'll get muscle tetany. Anybody know what tetany is? Just like contraction. And that's going to happen when more than one motor unit responds, and that's usually above that 35 pulses per second. So frequency, also pulses per second, pulse rate can be cycles per second, like we talked about up here, hertz. Those are all things that we need to associate with frequency. Ish. Alright. We have carrier frequency, which is just the base frequency of alternating current signal wave. So it's the frequency of an unmodulated carrier. The base, biphased, we turn the machine on, that's its carrier frequency. And then we can further modulate that based on all the changes we make with interpulse, pulse duration, all that stuff. The base frequency when we turn the machine on is that carrier frequency. And then, I might make you remember this, but it's found to be more comfortable to patients, specifically at that 2500 hertz. We don't need to worry about that. We just need to know when we talk about the carrier frequency, it's typically the most comfortable and it overcomes the skin resistance most easily at that carrier frequency. That's what I do want you to do. Then we have duty cycle, just like we have with the other modalities. And it's the same as it was with that, that's your on and off time. On time is the period of time that the current is delivered to the patient. Off time is the period of time when the current flow stops. So with the duty cycle, don't confuse that with that intra-pulse interval. Okay, so this wouldn't be the duty cycle. The duty cycle would be more of as we have the different pulses over time. If it was monophasic here, and then it skipped a pulse and then started here, that would be more along the lines of the duty cycle, that on and off time, not just these pieces. Does that make sense? It's not just the in-betweens, it's here's a pulse, this time we're going to take a break, and this time we're going to have a pulse again. That's more of that duty cycle. Where the other one is more that intra-pulse, pulse duration. Yeah? We also have ramp times. And on a lot of these older machines, you could adjust a lot more of this stuff. Those ones we have in the lab are kind of recent. We can tweak a little bit, but a lot of this stuff, those can't change as much. But you can change how long it takes for the current to go from 0 to peak, and how long it takes for the current to go from peak back down to 0, allowing the patient to hold a contraction for longer. So if we're doing some muscle strengthening, or if we're trying to activate some denervated muscles and tissues, we can change how fast that current hits them. So the way it has it here with that monophasic, where I'm going to draw this up there, it kind of starts less intense with the amplitude and then gradually goes up to where they want it to be. And then the off ramp would be coming back the other way where it would slowly go down. And then the same thing if you have that sinusoidal wave, it could be more here like that, or we could take it longer time. So those are all just, we can adjust that time that it takes for it to ramp up and ramp down. And a lot of these newer machines, we're doing that when we select different preset conditions on the machines. They just put it to a specific ramp time, a specific interpulse interval, specific pulse duration. We don't really make those changes, but by selecting a certain program on the machine, all of that stuff is kind of affected. And that's where it's important to find those manuals and kind of know, hey, if I do this, the ramp time is this, and the pulse duration is this, and the interface. So a lot of this stuff, we can't make those changes, but those preset conditions make those changes for us. So by gradually increasing the time that it ramps up and the times that it comes down, we get a more natural contraction, because when we have a quick on time and that muscle jerks real quick, that's not naturally how we move. We naturally, gradually, so it feels more natural and it's more comfortable for the patient. They feel it start stimulating and they know that we're going to get it up. It's going to be a really strong contraction, so they can kind of prep themselves for it a little bit, and it's a little more tolerable with a bigger ramp time. So just again, another way that we can modulate that modulation. Stability of electrical stimulation units to vary one or more of the parameters over time while still delivering the stimulus. So one or more. We can vary just one thing, or we can vary a lot of the different things. So not only does it help us make it a little more comfortable for the patient, feel a little more natural for contractions, it can also help prevent adaptation. Because if we set it at a constant ramp and we just did the same thing to the same voltage with the same intensity for 20 minutes, usually after 5 or 10 minutes, people are like, hey, could you turn it up? I kind of don't really feel it anymore. So then you turn it up. Having that modulation where there's different bursts, different on and off times, helps them not get used to it so quickly. And then we have sweep, which is basically just a term that says it's being modulated, and this is what the manufacturer does. So it's a term used by the manufacturers to say that they're doing some modulation of the pulse frequency, and it gives the option of constant sequential modulation through the available frequency, or just portions of it. And that definition changes depending on the type of treatment that you're doing, the type of machine that you're doing. But sweep is just basically a preset modulation. Does that make sense? That stuff's not really fun. The biggest thing I want you to know about modulation is it prevents adaptation. Any questions so far? Somebody's got a question. Cindy's there.
So for the, you said for the muscle, like you need innervation, and for the strengthening of muscle, do you use like the constant pump or?
Not necessarily. You can still do that slower ramp up. Most of the time, especially when you do Russian, when we get into that NMES, which is a form of Russian's a form of. You typically ramp it up slow because it's not comfortable for you to just sit here and be like here and here. So as we get into those settings, like typically what you're going to do is you put the pads on those muscles that you're trying to elicit contraction from, and you're going to turn it up, and you'll start to see it twitch like it did in the left, and then eventually it's going to really contract, and it feels really weird. It's that kind of level 3, 4 of the stimulation that we talked about, where it's not comfortable, you have no control over it, it feels weird, and then we'll turn it off and do the same thing on the opposite side for Russian, just do the extension if we need to. But then once you set it, you find where you need to make that contraction happen. Then you'll turn the machine on the program, and it'll slowly go up until it's always that peak, and then bless you. And then they're activating with that to try to help strengthen it. And then as it comes down, they can kind of hold and stabilize. So you still usually want to ramp up this stuff. Yep.
So modulation, so that would be the ability to change the electrical signal, like the pulse rate while you are like receiving it, basically, like while it's hooked up to your patient. You can change like the pulse rates. And then this prevents the patient from like, or the muscles from not responding, basically. So they'll build up a tolerance to it.
Exactly.
And then, so what is sweep? We're not understanding what you mean by the manufacturer.
So if you turn on, like, if I turn on whatever Premon or IFC or whatever we're going to do on the machine, it'll have its base, what it's going to do, and then I can press sweep, and it's going to modulate. I don't know what it does. It may change the interface interval, it may change the pulse duration, you know, It's just a way that they say, hey, hit this button and it's going to do some modulation.
Okay, so it's just like a predetermined setting that you really don't have control over, but the manufacturer's being.
And a lot of these are like that nowadays. Like, you know, all the ones we have in the lab, we can modulate a couple of things.
Yeah.
But like,
It's like that little one, the 5 different ones, so they're pretty much, they would be a sweep steady. So we didn't do much, but increase the
right.
intensity.
And
That's
then,
all that
yeah.
we did.
And then we look in the manual and we see that, okay, this is 80 hertz versus 150 hertz.
Okay.
This one varies between 80 and 150 hertz. So we don't know where it's going to be at any given time, but we know it's going to modulate between 80 and 150. So this time it turns on, it might be at 90. Next time it's going to be 80. Next time, and so that's that speed.
We would just let it go.
Yep, just
Like
another way
predetermined
we
factor.
modulate. Yep.
I was too confused to ask the other questions.
Autophoresis. We use electropulsive forces to introduce medicine into the body. The biggest advantage is that we avoid the liver, which is a major site of degradation. A lot of medicine that you take by your mouth, as it's processed through the liver, doesn't actually get out into the system. It gets broken down. And then we can use it to hit the localized transcutaneous tissues rather than more systemic. So always remember you have to give the patient a simple example of what you're going to be doing. Explain to them what's happening. That's where the magnet example works really well because everybody, most people understand that opposites attract, the same oppose each other. So we're going to use your medication as a positively charged medication. So we're going to put it under this positive pad and then it's going to push it away from the pad deeper into the tissues. Simple way to explain autophoresis. So we use small amounts of physiologically acceptable electric current drugs. Electrode of the same polarity as the charge of the drug drives it into the skin by electrostatic propulsion. Our dosage calculations is milliamps per minute. So milliamp is determined by multiplying the number of intensity, milliamps, by the number of minutes that the current is delivered. We talked about this in lab, for those of you that have the lab. If we're looking for a 40 milliamp per minute dosage, and we can get them to tolerate 4 milliamps, we're only going to be doing this for 10 minutes. If they can't tolerate that 4, they can only get to 1 milliamp, but we still got to get to 40, then we're going to be there for 40 minutes. So that's how we calculate the dosage. Most of the time, if they get a script and they bring their drug in with them, it'll have on there that we get a 30 milliamp dosage or whatever it's going to be, and then your job is just to make that happen. All right. Common medications. There will be a matching on the test for these common medications. So make sure that you understand them and you know what they do. So dexamethasone is a negatively charged medication. It is anti-inflammatory, so it's helpful in decreasing localized inflammation. Lidocaine is a positively charged medication, local anesthetic. Acetic acid. Biggest thing with this, we know that it works for adhesive capsulitis, calcific tendonitis. So using it primarily helps decrease those calcium deposits. It's also a negatively charged medication. Then we have copper, positive charge, mostly used for fungal infections. So fungal infection, just take that under the positive charge. Iodine is a negatively charged medication that helps with sclerotic conditions like frozen shoulder, and it helps improve local blood flow to the tissues to help prevent scarring. Salicylate, primarily used for plantar warts and inflammation. It's another negative charge. And then zinc is a positive, and it's helpful to treat dermal ulcers and wounds. Easy peasy. And then one of the big contraindications for iontophoresis is allergy. So when they come in and hey, I got this script for iontophoresis, here's my medication, and you look at it and you say, hey, do you have any allergies to dexamethasone? And I know it seems like a silly question, but sometimes the doctors don't ask. They go get their prescription, they go to the pharmacy to pick it up. The pharmacist sees that they've been prescribed it, they may not ask, and then they come to you. So just ask. It may seem like a silly question, but if they're allergic to it and you sit here for 10 to 40 minutes pumping their system with it, it's a problem. So just check, make sure. Let's take a little breather, we'll do one more. Water, typically some type of sponge or something like that. So they're made out of steel, aluminum, zinc, whatever, good conductors. Originally contained in a rubber casing with only one surface area exposed and accomplished through a sponge. And then the big thing is we had to use distilled water, or couldn't use distilled water, and that's the same thing with these pads. If we're trying to lessen the resistance of the skin by putting some water on the electric pads or on the patient itself, a spray bottle or something. You can't use distilled water because there's no free ions. It's distilled out of there. We want those ions because that's what's going to help conduct that electricity. Then we had carbon impregnated rubber electrodes. You still see these sometimes more in a hospital setting or more specific type of settings, but they're made out of rubber, silicone, some type of polymer. Not commonly used in clinics, sometimes appropriate for the area being treated. The electrodes back with a non-conductive material to help prevent unintentional current delivery if they brush it up against something else. And then the common ones that you're going to see most of the time are these self-adhering electrodes, which are single use or reusable. And they're composed of other flexible conductors such as foil or a metal mesh, whatever that is, synthetic gel. So they got the gel on the back, but inside that electrode are usually like little grid wires that when the electrode that plugs into the bottom goes out among this grid, you don't really see because you see the gel part. Sometimes you can turn them over and look at where the gel is and you can see that on the grid. I think a couple of ones we used to come out this week were like that. But the best advantage to these is because they're easy to apply and reuse. So the method of current delivery into the electrode will also affect the uniformity of the delivery. Some of the self-adhering electrodes have the metal wire that goes right into the center and then spreads out on the back conductive surface. The delivery at the point of attachment where that wire is going to be relatively higher than the current to the periphery of the electrode, which can result in a hot spot where the wire connects to the electrode. Ideal world, we'd have uniform conductivity, but that's what the foil and mesh surfaces inside those electrodes is for, is to help spread it out and not get that hot spot where it plugs in. Another thing to keep in mind is when you're putting them on people, is try to put it to where maybe that cord is facing down. Right? So like if I was putting it on someone's upper back, I'm not going to put the cord up here, because then with gravity and everything's going to pull on that wire and it's going to start to peel that electrode off. And the less of that electrode that's touching the skin, the more intense the electricity is going to be. There's less surface area where it's spread out. So a lot of times you put pads on people, you give them a hot pack around their neck, and while you're putting the hot pack on, you peel up a little corner and you go to turn it up and you're saying, all right, how's that feel? And they're like, oh, it's kind of stingy. That should be your first thought is, let me look and make sure we still have a good connection, because as that surface area decreases, we get that same kind of hot spot and it causes that prickling, like stingy sensation. And then current density is the amount of current concentrated on the electrode. It's going to depend on the size of the electrode. Ones we use in the lab are the small little square, the circle ones that are about the same size. But the bigger the electrode is, the more that current is spreading out across the electrode, so you may have to turn it up more in order to get the same effect as you would on a smaller electrode. But sometimes we just need that bigger electrode. So the smaller we get, we're delivering more high current density because of the surface area. And then therapeutic stimulation involves active stimulating electrode and dispersive electrode, which we've AC, even the direct current sometimes. But with the AC, if one of those pads falls off, then you don't feel anything. With direct current, one could fall off and you can still feel it because it's flowing from one to the other. A lot of times why you won't feel it with just one is because it's alternating from here to there and from here to there. So when it falls off, we're not getting that other half of it. Lead wires provide the conductive path for current flow. You'll always have a pair of leads coming from the electrical stimulators. They're the intermediary between the generator and the electrodes. And lead wire has several parts. Point of exit from the stimulator, the wire itself, and the point of attachment to the electrode known as the tip. The point of exit is referred to as the jack, and if it has two leads, it's referred to as a stereo jack. And like this one over here, some of them you plug in and it only has one attachment for a lead. Most of them are those stereo jacks where you plug it in and it has two. So electrodes applied to the surface of the skin are termed transcutaneous electrodes. You also have percutaneous electrodes, ones that are inserted into the skin. You don't see too many of those unless you go get an EMG or a velocity conduction test, and then they'll put those needles in you and they'll send signals from one end to the needle to test your nerve conduction velocity. They also have some that are permanently implanted also. They don't do that as much anymore. People used to get them in their spine. It's like people that have had like lumbar surgeries and they still have pain, The doctor's like, fine, put an electrical stimulator in there. It's just constantly going, recharge it. They don't do that too much anymore. But you still see some patients that have them, which when you're doing electrical stimulation, it's a good question to ask. Do you have any other electrical devices? Because we don't want to fry that and then now they have to go have surgery and get it taken out because it doesn't work anymore. Monopolar application, single electrode from the channel, usually smaller, placed over a target area. It's an active electrode. You get the greatest stimulation at the target area with that. Larger dispersive electrode is placed at a distance away from the target to complete the circuit. Placement's usually over a nerve root treatment. So if you're working on C7 kind of dermal tongue, you work on something in the hand, put that at the nerve root while you put the other one over closer to muscle we're trying to activate. And bipolar, 2 electrodes from one channel within the target area. Current flow through the tissues confined to the treatment area. 1 electrode over the motor point, where it takes the least amount of current to elicit the contraction. The other electrode, which may be slightly larger, placed somewhere else over the muscle belly. That's kind of more close to what we were doing in the lab. We're trying to get activation here. The other one's over the muscle belly. Occasionally you can bifurcate or split the leads. You don't really see that often. That's it. Just a little bit about leads and wires. So, easy peasy. Now, you guys gotta help me make test questions because I deleted a lot and I need some more. So, let's do our test question stuff. Just splitting the slides up.
For which one?
Let's do,
Slides.
how many were these
Like 6.
things?
Way too many. 1, 2, 3, 4, 5, 6, 7. 7 cells.
Let's do, we don't really need them from that last one. Just 2 slides. So just split up the 2, part 1 and part 2 of the electrical stuff. Maybe this group will take like the first 15 slides of part 1, and then this group can take like the next 15-ish slides, so it'll get you into the first few on part 2, and then the last group will take the last half of the part 2 PowerPoint. Does that make sense?
No.
Okay, I figured it out. Yeah. Just maybe some tests.